Hi everyone, welcome back to another video from the Aspiring Medics. As always, my name is Yusuf. I'm a final year Oxford medical student and I'm joined by Megan. Would you like to introduce yourself?
Hi, I'm Megan. I'm a first year medical student at Oxford. And yeah, I'm studying at St Anne's College. So yeah.
Awesome. So of course today we're going to be going through an Oxbridge mock, and these are usually anywhere between 20 to 30 minutes long, and without further ado, we're going to get straight into it. I'm going to be the interviewer. Megan has very kindly agreed to be the student as well. And as we're going along, also at home, think about, okay, how would you answer that question? And think about it. Also from a perspective, because it's about what you're able to piece together, how you're able to create a story. It's effectively how you think as opposed to what you know. It's not a content exam. It's not something that's testing your knowledge. It's testing how you're able to think and how open-minded you can be. So have a think about that as you're watching this video. All right, let's do it. So Megan, welcome and thanks for joining us. I'm going to go straight into it. I can see actually from your personal statement you've done some work experience. Can you tell me a bit more about that, please?
Yeah, so I did a period of work experience on a geriatric ward, and it was a very busy ward, quite big. So obviously I was exposed to some of the pressures people were facing. As we all know, there's limited capacity in terms of the workforce in the NHS. So I was really exposed to how doctors and healthcare professionals are having to prioritise, to work on priority tasks first, and make sure patients are seen to in a timely manner. And how they're communicating with patients as well about those delays and pressures they're experiencing, so that everyone's aware of the situation and is understanding of that. There was one particular patient that really stood out to me during the week, who was a stroke patient. And I think they really stood out to me because they were really just wanting someone to communicate with them. They were very, very confused, obviously, naturally. And so they were sort of reaching out to the doctor and saying, where am I? Because they, were just quite confused generally, and asking for certain family members. And it really sort of brought home to me the importance of like that integration between medical science, so actually physically helping the patient as well as making sure you're openly always communicating with them, because medicine's really got those two facets of that sort of emotional side as well as that scientific, physical side as well. So yeah, but yeah, she was the main patient that really stood out to me. And it was overall a really, it was a varied week, but I thought it was really beneficial for helping me decide to study medicine.
Great, excellent. And some candidates have also mentioned that sometimes in hospital, there are patients that stay a very long time in hospital who are medically fit. Can you think of reasons as to why they might not be able to go home straight away?
So I think one of the biggest problems is probably access to social care provision. So obviously social care experiences lots of the same pressures that the NHS do in terms of the workforce and having enough healthcare professionals within care home settings to be able to look after patients. So there's capacity actually in social care for patients who couldn't go home and live independently. There's also factors relating to transport, getting them actually from the hospital to a social care setting. Obviously, that would normally typically be done in an ambulance. But again, ambulance staff facing similar pressures with increasing numbers of calls, particularly during the winter season. Obviously, they're seeing high numbers of calls for things like falls, and then there's more ambulances being called out to those sort of events and less that are able to just be used as transport. And there's also the process of discharge that sometimes can take a long time. You need a doctor available to carry out a discharge form, and if doctors are working on other tasks, they might not be able to immediately get through those discharge forms and get patients out of the hospital. So those are sort of main factors I could think of.
Okay, fantastic. And during your working experience as well, can you remember any patients that had a specific condition at all?
I mean, as I said, the main piece of work experience I did on the geriatric ward, and there was like a lot of patients actually with strokes there. I talked about that one out to me. So I'd say.
And I guess with that, if I may, can you tell me a bit more about like what your understanding is of a stroke and what happens in a stroke?
So from what I understand, it's where there's an area of the brain that essentially loses a blood supply, and so that the tissue or the cells in that area essentially start to die. And then that causes some of the sort of neurological effects you can see with sciating also the face or loss in movement or feeling, I think, in like sort of one side of the body, depending on where obviously the blood supply has been lost in the brain.
Yeah, and why is blood supply being lost? Is it what causes it?
It could potentially be a clot, maybe in a blood vessel. Then the blood gets blocked and can't reach those cells. That's sort of the main thing I would think of with that.
So how do we go from a blood vessel being blocked to all of a sudden resulting in symptoms, as you say, of tingling or loss of motor sensation? Can you just walk me through and break that down for me?
Yeah, so obviously blood carries oxygen, and so if the oxygen in the red blood cells sort of bound to the hemoglobin isn't able to reach the cells in the brain, the nerve of the nervous tissue, then those cells won't be able to respire aerobically, and so they won't be able to generate the ATP they need to carry out certain metabolic processes, and then that will ultimately result in those biochemical sort of reactions not being able to take place, and then those cells can't carry out their function within the brain. So say those are cells that are responsible, or an area of the brain responsible for movement, then they won't be able to carry out or aid in sort of being able to move or detect stimuli and then kind of respond to that, because that's sort of the main function of the brain, I guess.
Good. Okay, so you've explained that cells could die or not get the oxygen they need to aerobically respire. How do you go from that to then having this loss of sensation or motor sensation? Can you talk me through that a bit more?
Well, if we think about how we can sense things in the first place, that might be helpful. So obviously there's like a sensory nerve, and then that connects up to a relay nerve in the central nervous system, and then a motor nerve that allow that sort of reflex arc to take place on that like response to, say, like touch or like a hot stimulus and you're pulling your hand away. So if those relay neurons or neurons in the central nervous system are then are damaged or start to die because of a stroke, then you essentially cut out part of that arc. And then even if there's a stimulus detected and sensory nerve is able to respond to that, then even when it reaches the central nervous system, it won't be able to be relayed to motor neurons. Potentially, that's sort of why.
Good. But why is it, for example, that a stroke patient could, for example, have symptoms that, let's say, it affects their arm, and they're not able to raise their arm, the classic stroke that you see in a stroke advert, for example? Why is it that it just causes, say, paralysis of their right arm, as opposed to paralysis of their whole body?
Well, I guess there's particular parts of the brain which control function on different sort of sides or orientations. So as I was saying before, it sort of depends where the blood supply has been cut off to, because you've got kind of two hemispheres of your brain. So there's obviously different sections which correspond to different arms and different relay neurons that are connected to the sensory neuron in each arm, which would then affect function on your one side, depending on where the blockage is.
Great, that's absolutely fantastic. And that kind of leads us quite nicely onto our next part of our session. And of course, stroke, particularly cardiovascular disease, is a major risk factor, particularly for men. But also, as we age as well, it can also increase your risk of dying. And so I wanted to show you this graph here that I've prepared for you. And I will share my screen now. And firstly, I just want you just to walk me through what you can see so far. And I'll share my screen now. So firstly, could you just describe what you see, please?
So I can see that the graph's got health expenditure per capita along the x-axis, and then life expectancy at birth is on the y-axis. And then we've got these sort of different lines. So I think they're corresponding to different countries, from as far as I can see. So there's a line for New Zealand, and then there's a line for the United States and for Japan. And then it's got data from different years. So I think it starts in 1917 for all of the countries, and then the data seems to end in 2015 for all of the countries.
Great, okay. So again, can you just provide me further details? So at the moment, who's got the greatest life expectancy based on 2015 data?
So based on the 2015 data, Japan have the greatest life expectancy.
Okay.
And then we've got the United States has the lowest life expectancy from birth in 2015, and then New Zealand's in the middle. But compared to the 1970 data, actually, I think you see the same trend. It's just not quite as it's separated. Like it's become more, it's diverged kind of over time. Like the data in 1970, although Japan still had the highest life expectancy, it was closer to the life expectancy at birth for the other two countries. But now it seems to have diverged a lot more.
Yeah, so you talk about diverging. Let's now think about this in terms of the X and Y axis and what that diverging shows firstly, and then we can try and explain it. But what does it show? You mentioned diverging. Can you provide a bit more detail in comparison to these three countries? We've got US, Japan, New Zealand.
So it shows that the health expenditure per capita has gone up massively, particularly for the United States between 2015 and 1970. And it's also increased for Japan and New Zealand, but not to the same extent it's increased to the United States.
Great, very good.
We've also seen a massive, quite a big jump actually in life expectancy at birth for Japan, despite that kind of smaller increase in health expenditure per capita. And it's sort of a similar situation for New Zealand. It follows the same kind of trend, but for the line graph for the United States, it increases. The health expenditure is increasing massively. There's a much slower increase, a slower rate of increase of life expectancy with that increase in health expenditure. So yeah.
How can you tell it's a slower rate of increase?
So it's a line graph, so the gradient's not quite as steep for the graph for the United States in comparison to the graphs for Japan and New Zealand.
Yes, but what is it a rate? It is a rate, but what is it a rate of? Because is the x-axis over time?
So it's not a rate as such. It's a comparison between health expenditure per capita and life expectancy at birth.
Yes.
So it's basically the change in life expectancy relative to health expenditure. And you essentially, for Japan and New Zealand, they've had to increase their health expenditure less for life expectancy to increase.
Sure, but you are right in your original statement, though. You were right in saying that actually in terms of the increase in life expectancy as a rate, that is higher. But it's not because of the gradients of these lines, because we say X and Y is different. The x-axis isn't for time. How can you say that the rate of life expectancy has increased the fastest for Japan?
You could say, I mean, you could just say relative to the years, because 2015, the life expectancy in Japan is the greatest in comparison to 1970. So you're just assuming over that time their life expectancy has increased at the fastest rate. So it's actually to do with the years.
Yeah, very good, very good. Because this is a snapshot, right? This is looking between 1970 and 2015. And roughly speaking, US, Japan, New Zealand started off at roughly the same. But it's quite clear that Japan is clearly quite higher. So that's how you can say it. But absolutely. So it's worth really making sure you're looking at the X and Y axis. Very good. Okay. Anything else you could comment upon? So if we're now thinking about the gradient that you did mention, actually, so if we actually now look at health expenditure over life expectancy, what is your sort of bullet point headlines so far on what this shows?
Well, I think it shows that the increase in health expenditure in the US is obviously not being as effective as they would want, because it's not resulting in a greater life expectancy at birth. In comparison to Japan and New Zealand, which are spending much less and having better health outcomes, higher life expectancy. So I'd probably think there must be other factors that are affecting health in the US, because obviously you'd assume if there's a higher health expenditure, then there's a greater quality of healthcare. But perhaps not everyone's able to access that healthcare because it's too expensive, almost like a premium of the.
Great, and now you're going into reasons to explain it, which is fantastic. But if we just pause now for a second. So you've absolutely analysed this right. So effectively what we've got here is that increased health expenditure doesn't necessarily result in increased life expectancy. And we've seen this clearly here. So firstly, what is life expectancy?
Life expectancy is the sort of average number of years someone can be expected to live, because from when they're born, this on the graph, it said that it was life expectancy from birth. So they're estimating from a baby that's born how long, what's the average time, number of years they should be expecting to live after that.
Okay, great. And we'll talk about that a bit further in my second graph, but how do you think that would be determined? How do you calculate that?
So you could have a think about, well, obviously you need quite a large sample size to be able to make that sort of way to calculate that sort of average. You'd want to, because it's from birth, you need to take into account people dying at all ages. So even if somebody dies particularly young from, say, like childhood cancer or something like that, those factors and those figures still have to be included in the data because it's an average from birth. So you want a large sample size of people, basically follow all those people through their lives and then record perhaps the year they, like how old they are when they die. And then you take an average of those scores during that sample size. And you want to make sure you've got a varied demographic within that sample size of the country. So you want people of all races, of all socioeconomic backgrounds. So basically, yeah, that really large varied sample size, and then take the age at which they die and then use that as an estimate. But you'd probably want to carry it out multiple times in each country just because it would make your estimate more precise.
Interesting. We'll talk about this a bit further, but very good. And what's health expenditure?
What, sorry?
What is health expenditure?
Health expenditure is referring to the kind of the average cost, perhaps, or like the average spend that is spent in a country on healthcare provision, so healthcare resources, and that could include hospital equipment, that could include paying healthcare professionals, and that could include support for social care, that could include medications, so perhaps government subsidies for medications. So really it basically is money spent by the government relating to, or money spent by the country in general, or maybe not the government, because obviously not all of it's funded through the government, but relating to healthcare provision. So that can encompass.
Okay, healthcare provision. And it's interesting that you also said social care as well. And that's the devil's in the details there, right? Because that may or may not be, as we know in the NHS UK system, it's separate pots of funding. So that's important to think about. But also expenditure. What does expenditure mean? Not a trick question.
So expenditure is just how much money you spend, essentially. Yeah.
And who is spending that money?
So I would say this sort of depends. I would assume health expenditure, obviously in the UK, is how much our government spends because the NHS is funded through the government. But you could potentially, if you're thinking about countries such as the US, where healthcare takes place through private companies or through insurance companies, you could potentially be including the money that's spent by those insurance companies as well.
Yeah, good, very good. And it also very good. So again, it depends. All I'm trying to say is, is think about who's footing the bill, right? So is it going to be the government? Is it going to be individuals? Is it going to be councils? To what extent? How are you going to measure that? And also, health really is, of course, intertwined into everything. Can you give me some broader examples of health expenditure? Not the ones you've mentioned. So you've thought about sort of quite direct ones. Can you think about some indirect ones?
Indirect ones, potentially health expenditure when on potentially air pollution schemes or things that can be used to prevent somebody becoming ill. So maybe the implementation of like a low emission zone in a country could count, because that obviously has a knock-on effect on health. Maybe public health campaigns, like potentially a campaign to discourage smoking in populations, or discourage excess alcohol use, similar to campaigns to prevent like sort of drugs, like excessive drug use. And yeah, so more sort of public health campaigns, I guess.
Yeah, exactly, more public health. Okay. Would you consider family planning to be healthcare?
Yeah, I would say that too. So maybe contraception and those sort of things.
Good.
And sexual health as well, potentially.
And how about nutrition, sanitation?
Well, yeah, nutrition. So you could have I think in the UK there was the 5-a-day campaign and the Eat Well plate that was kind of put out for a lot of schools to try and get children eating well, eating a balanced diet from a younger age. So that sort of campaign obviously need funding and need supporting. So that's probably another example of that in terms of nutrition.
What about sanitation? Do you think it should be? Do you think it shouldn't be? What is sanitation, firstly?
Sanitation sort of like hygiene, so how clean maybe the streets are, how clean people's houses are. So it kind of encompasses things like sewage works and preventing kind of the spread of disease through or communicable disease through bacterial viruses that are in kind of dirty areas or like from contaminated material. So I guess sewage comes under that, and then general cleanliness of public spaces.
So would you consider it as healthcare expenditure?
I think I would consider it as healthcare expenditure, because obviously people can catch, if you had sewage flowing through the streets, people could catch quite a few communicable diseases from that. So I would still consider it healthcare expenditure because it's helping to prevent people becoming ill from those sorts of infections.
Yeah, that's very interesting. I can absolutely see your point. You're very generous there, but generally speaking, health expenditure excludes stuff like sanitation. But as you say, clearly it's very important, and it will have massive consequences if it was all of a sudden taken away. But it's very interesting nonetheless. All right, we're going to move on to our next graph now. What's going on here? Can you firstly describe it?
So in this graph, we can see the age in years along the x-axis, and then we've got the percentage survival at a period rate on the y-axis, and it's at the top it says the data is for males in England, and it's got 3 different lines for different years, so 1910, 1960, and then 2010.
And what is it showing?
So it's showing, so for example, in 1910, it's the percentage survival of those males in England. It doesn't give any figures for the number of males. I'm not too sure what period rate means, but it appears that in 1910, the percentage survival really decreased from the age of about roughly 10 years old. The percentage survival decreased, and well, in 1910 compared to 1960 and 2010, the percentage survival was lower across all age groups. And then in 1960 and 2010, there's a lesser difference between the percentage survival across all age groups, but the percentage survival was still lower in 1960 than it was in 2010. And there's a more rapid decrease, however, in the percentage survival from roughly the age of like 60 in 1960 and 2010 than there was in 1910, perhaps because sort of like child mortality was more common. Yeah.
Let's just analyze that for a second. So you are right in the sense that, by the time you get to 60, we've got a rapid decline that we've got according to this graph at least, that you can see here. But you said that there was a more rapid drop off in 1960 2010 than there was in 1910 during that same period. And you said that, well, I guess firstly, let's look at 1910. And you've mentioned this already, but why is there a steep decline under 10 years old?
Well, there's a sort of, in 1910, it was more common for children to die in childbirth or for them to die as infants from certain infections potentially, or because vaccination programs, obviously, like child vaccination programs weren't implemented in 1910, whereas in 1960 and 2010 they probably had started to be, or they've been properly implemented.
Good. Vaccinations. What else? 2 other things also to keep in mind.
Another thing I would think is, as I said, sort of childbirth, like children dying actually as soon as they're born, because there's many like childbirth related, so when a baby's being born, there's obviously complications that can occur, and then children can just die in childbirth. Do you think that would be a factor to consider for that?
Yeah, it could be. Absolutely. It depends exactly when it counts. If they're also counting, as you say, sort of prenatal or antenatal deaths, but I assume they would. That's good. And you said vaccinations. What else? 2 other things.
Could potentially be related to deficiency diseases. I know that obviously when a child's growing, it's really important that they get adequate nutrition, and potentially for certain children, certain backgrounds in 1910, those sort of public health campaigns were implemented to ensure that all children were getting a balanced diet. So I think there were certain conditions like, I'm not sure if rickets is one, but I think there was certain kind of deficiency diseases that were more common in the early 1900s. So potentially those are causing some fatalities, although I'm not sure how many of those lead to fatalities rather than just deformities.
So far you've mentioned vaccinations, nutrition. Anything else just in terms of factors, if you just list off different factors?
Cleanliness, we talked about sanitation earlier. That could be a factor. I don't know, maybe there wasn't as good regulation on things like sewage and use of toilets and just general hygiene of public spaces. So potentially that's leading to some childhood deaths, although that would obviously affect all ages, I think, but children don't have as developed, well, very young children don't have as developed of an immune system. So potentially as babies, they're more susceptible to those sort of communicable diseases.
Good. So you've mentioned probably 3 things there to do with prevention. So you mentioned nutrition, vaccinations, for example, as well. What else could also come into play? Thinking about management potentially.
So maybe if children are born with certain conditions, then, for example, asthma is quite common in certain children. Maybe there wasn't I'd imagine there probably wasn't the inhalers or medications to manage asthma, and then that can obviously then develop into a more serious condition if it's not sort of managed or seen to. So
that's true, but I'm not sure if there was a massive burden of mortality from asthma in children 100 years ago. Can you think of anything else that historically has been a massive burden?
Maybe management of childhood cancers, although I'm not sure if that's so much.
Again, that's quite niche, isn't it, really?
Yeah.
And if you look at present day, it's fairly more rare and uncommon, but I'm sure you can think of stuff in terms of snotty children. So what can also happen to children if we're thinking about that?
So potentially so we talk about asthma, they talk about asthma. Could it be related to, so we talked about vaccination, so it's not communicable disease.
Well, what are vaccinations also for? So what are vaccinations for?
They're used to prevent communicable disease. So certain viruses, things like polio and was a lot more common maybe in that sort of period, but now people could get vaccinated for polio after 1910, so maybe that sort of thing. So maybe catching infectious diseases, like all things like pneumonia could be a problem. I know that like young babies' lungs aren't very well developed, so sort of respiratory condition.
Yes. Okay, that's now we get, so pneumonia. What's pneumonia type of? What is pneumonia?
It's an infection, so it's
of
the lungs.
Good, yes, exactly. Of an infection of the lungs, like a chest infection. What, broadly speaking, are the 2 main types of pathogens that could cause it?
Is it bacteria and viruses?
Yeah. We've spoken about vaccines. So which one of the 2 do you think has probably had the greatest reduction, do you think? At least in terms of the management of it.
Probably bacterial pneumonia, I'd imagine.
Why?
Because if we think that viral pneumonia is probably harder to vaccinate against because viruses tend to inhabit host cells, so it's harder to be able to sort of create a vaccine that's able to target viral pneumonia, because it won't be able to recognize antigens on the surface of the virus because it'll be hidden within the sort of self antigens that are on your cells. So I think
okay. And what treatments do we have for one of those that has really skyrocketed in the last 100 years?
For bacterial pneumonia, it's probably antibiotics is the main treatment.
Great. Yeah. Because a certain Mr. Fleming came along in 1928 with antibiotics and penicillin, and that was a massive game changer, right? And of course, that has also led to consequent effects of that, of overuse, but maybe we'll talk about that later. All right, very good. And what's happened actually to the maximum age, do you think, in terms of how long people are living for in this
So
graph?
it has increased. It's increased much more greatly between 1960 and 2010 versus between 1910 and 1960. There was a small increase in the sort of like maximum age that's being reached between 1910 and 1960, but there's quite a bit more of a difference between the maximum age in 1960 and 2010.
Yeah, not a lot though.
Not
And we don't know, especially 1910, 1960. We also don't know, we don't have any bars, data bars here, so we don't know if that's what would be interesting to have a look at. If we had some data bars, what would we want to know?
We'd potentially want to know the kind of like the range. So just survival or the standard, or the standard deviation from that average value. Because obviously we don't know how many males this is taken from. It just says males. So this could be like the sample size for this could be really small, and it could be just 20 males in each year. So you want kind of, if we had data bars, we'd be able to take an average of the population and see how much the percentage of survival deviates at each age, like each age on the graph.
Good. Why would you want to know that? Why is that important?
Because then that gives us more of an idea of kind of how accurate, precise our data is. If we've got a massive range bar, it's suggesting that perhaps we can't kind of trust that percentage, particularly the average percentage taken, because I mean there could be anomalies obviously in the data, but, which could then make the range bars bigger. But say there, say we had just generally quite a large range bar, then we'd assume that the percentage of survival isn't really, even when we take an average, it's probably not really around that figure, because we can't really take a, as I was saying, we can't really trust that number if it's got such.
Correct. And that's exactly what data bars or error bars, give you, right? You're thinking about, okay, where is the actual true average lying between it? And you're using probability, different standard deviations to work out the probability of the true mean average being at that point. Good. But so what happens then if you have two different bits of data that have overlapping data bars? What does that indicate to you?
It indicates that there's obviously data from, so say you had two overlapping data bars from age 10 and like age 11, or say age 10 and age 30 to be sort of moving further apart. It sort of suggests that there's not adequate enough data, or maybe you've not got a large enough sample size to create a good estimate, because it's showing that technically the percentage survival at age 10 and age 30 is the same, which you sort of wouldn't expect. So that's sort of what I think of that.
Yeah, exactly. It means that, it's less likely for those bits of information to be statistically significant, right? Because you've got that overlap. So you've got statistically significant, but then you've also got clinically significant. Between 1910 and 1960, well, 1-2 years maybe. I'm not sure if that would be, of course, it would mean a lot to someone, but it could also mean a little less. So it's also thinking about what is the actual relevance to it in practice as well, thinking about clinically versus statistically significant in general. But why is it then that really the maximum age hasn't changed a lot? Why is that?
I think it's because sort of when we get to there's a certain period kind of from like, I mean, on this graph, it's kind of from 70 to about maybe 80, roughly, where we see a massive drop in percentage survival. And it's because people tend to be affected by certain diseases such as cancer or cardiovascular disease at those ages. And the people that then, you only get a very small number of people who survive like much longer, so to say like 90 or 95. So potentially it's just that there's not many, it's quite sort of, those diseases are affecting people at a certain age maybe, and then it's like they're not living longer, and then there's only a small number of people who are living like beyond that. I'm not too sure if that's
so why is it? So why is it people, don't live longer?
I mean, I guess we could think about like the management of those conditions. Like certain conditions, like say like cancer, is obviously like in all of these years, 1910, 1960, 2010, obviously the treatments have been massively improved in terms of cancer treatment. But in 1910, people used to die from sort of more communicable diseases younger, and then the people that then survived longer, we had like less cancer cases. So that's why you see like the decrease from like 70 is not steep as like 1960 and 2010.
Yeah. But
But
why is it that of these like super ages, let's call them, why is it that, 2010 you think, oh, okay, they've got a lot going on there, or 1960, why aren't they living to 110 or 130? It doesn't really, the maximum age really hasn't changed that much. Why? What is going on there?
maybe, as I said before, maybe it's just the management of those, like a condition such as cancer. We obviously don't yet have sort of a comprehensive treatment for all of them. Even in 1960 and 2010, the management improved, but there's certain people who are still going to die of those conditions because we still don't have a sort
Okay.
of.
Any other conditions you think that could affect things? So cancer's a big one. Good. Anything else?
Maybe neurodegenerative disease, because again, we sort of don't have a similar treatment procedure for those sort of diseases. So that could be another factor.
So which one are you thinking about there?
In
neurodegenerative diseases.
What specific neurodegenerative disease do you mean?
Yeah.
Could be things like maybe Parkinson's or Alzheimer's, because in 1960 and in 2010 we don't yet have a curative treatment for either. So like people that not.
That's true, absolutely. We do at least have some symptomatic management that we can absolutely give for people with Parkinson's, but particularly for Alzheimer's in particular, we don't really absolutely have a cure for it. And so, as you say, we're sort of reaching our knowledge limit when it comes down to those. Can you think of any other reasons? We focus a lot on pathophysiology, I guess, in terms of diseases. Can you think of any other reasons?
I guess maybe if we think about wider sort of maybe public health factors, there's people who reach a certain age, so say like, I don't know, 90 or 95, obviously they'll probably struggle to live independently. So we could almost relate it back to kind of social care and like how are we able to support people of that age, and maybe there's not the reason they're not reaching those really high ages is because we can't support people beyond, say, like, or maybe we struggle to support people beyond, say, like 95 or 90. So maybe there's like a sort of more a wider factors affecting people of that age that's meaning that the maximum age reach is just not increasing.
Okay. And also, do you think we should treat aging as a disease?
Oh, I think we shouldn't treat it as a disease, because obviously the process of aging, it kind of comes in many forms. A lot of people associate aging with you getting certain non-communicable diseases, things like cancer, cardiovascular disease, or like a neurodegenerative disease. But obviously aging also, you can describe physical aging where you get wrinkles, and aging is just sort of the process of becoming older. It's not always associated with disease. You can have people who live to 105 and potentially would never have had a long-term illness. I mean, I think that's unlikely, but I wouldn't say you could associate aging with disease like that, because there's obviously cases where that's not true.
And so another reason as to why there is this, at the moment, it almost seems an upper limit at a certain extent, is just because of aging, right? It might not even be because of a single organ system or even a multi-system organ disease as a whole connected pathophysiological process. But it's just because everything altogether, wear and tear, really, everything in terms of all your organs as they get older, as the telomeres shorten, therefore means that you're getting worse and worse copies of your DNA. And that means everything therefore just won't function as well. And so eventually it gets to a point where physiologically you won't be able to function. So that could be also another reason why. It's just the general aging process. But it can be very common just to want to describe certain aspects or a certain disease or cause to it, which of course can contribute, but actually it can also just be down to aging in itself and frailty. Good. All right. So my last question in this graph for you is, where do you think this data actually all comes from?
So they potentially got it from kind of hospitals. So if we're looking at percentage survival, it's obviously mortality cases. So those are normally recorded in hospitals. So they probably got hospital data. If people have died at home, it'll be like a death registry service. So maybe they get it from a list of registered deaths. and obviously the ages of each person is recorded. And it's all in England, so it's obviously just like the death registry service within England. I mean, we don't know how many people they've sort of used in the sample. They could have only taken like a selection of deaths in each year, or let's say like all of the deaths in February, or but yeah.
Okay, so if we go back to the graph as well, so for 1910 data, you're saying basically in terms of registers of births and death certificates as well.
Yeah.
What about those born in 19? Also, something important to say is that for 1910, 1960, 2010, these are the age at which they were born as well. I'm going to say that again. That's the age at which they were born, the
Yeah,
year
okay.
that they were born. All right. Anything else you might want to be thinking about?
In terms of where they could get the data from.
Yeah, so that's one you've given. Anything else?
So they could have gotten it from maybe. So we talked about death registry hospitals, maybe from social care, maybe from care homes or primary care. So like GP practice, although I guess they have to register them with the death registry as well.
Sure. So in general, you're thinking of birth and deaths in terms of, endpoint, start point for individuals. Sure, that could be one way. Anything else you can think of?
Percentage survival. I mean, we're looking at certain. I'm not too sure actually.
Okay. So another way of doing it is also looking at estimates. You could start to divide it into different populations and segments. Any thoughts on that?
So I guess if you're dividing it into specific population segments, you take all the. I mean, we could segment them by years and say, okay, we're going to take all of the 10-year-olds, or like this selection of the male 10-year-olds born in 1910, and then sort of follow them, and then just record the number that die, and then do that for sort of all age groups. I mean, they're segmenting in terms of males as well, so we got to target males.
Good. So you're still thinking globally, but what about in terms of segmenting it in terms of causes of death and death rates of conditions?
So, okay, if we need to track it by certain conditions, then, okay, we could look at where those, I mean, are those kind of conditions, I guess they're recorded with the hospitals though, and they're like practitioners. So you could get that from there, or maybe these individuals are going to reporting their condition to like their doctor, or I'm not too sure. I think.
So if we choose an example, can you remember, let's choose, something that's got a high cause of mortality, something we mentioned right at the start.
Yeah.
What condition was that we spoke about?
So we talked about infection in 1910 causing high mortality in children. Or pneumonia specifically.
Pneumonia is one. And what was the other in males in terms of in their 50s and 60s?
We talked about cancers as well.
Cancer in general with age, yes. But what about specifically in males? What are they also at highest risk factor of that you mentioned in your work experience?
Strokes, yes.
Strokes, fantastic. Okay, so you can then think about, okay, well, how would you go about that? How do you use that specifically if you're thinking about, let's say, prevalence, if you're thinking about death rate? How could you use that to then calculate a death rate or survival period rate?
Okay, well, we need to find out how many males have had a stroke to look at how many sort of survive. So if we, okay, 1910, 1960, 2010, we need data from stroke patients from each year. So we need to basically look at who treats stroke patients, like who finds them, and then how many, because we might actually miss a stroke. So we need to identify all the people that have a stroke. So people might go into hospital and doctors aren't sure if they've had a stroke necessarily, and those people could then get missed off our data. So we want to make sure that basically all the stroke patients, or as many as possible, are identified and then put onto through medical notes, and it's written on the notes, this person suffered a stroke, and then we kind of collect those patients are sort of put into a separate section, and we collect those patients up, and then we can work out percentage survival by looking at the total number that had strokes and then the total number that sort of survived after strokes.
Yeah, perfect. Great. Okay, that's fantastic. And the one thing, lastly, to draw your attention to on this graph is that As has been mentioned, we're looking here at the number of males that were born, basically the birth year effectively for 1910, 1916, 2010. And then we're looking at their ages.
Yeah.
I don't know about you, but I don't know many 90-year-olds that were born in 2010. So what happened there?
Ah, I see. So they've probably extrapolated the data. So they're making an estimate of the percentage survival for people potentially. They're just following a trend. So they're kind of using the pattern for, I mean, even for 1960, they've still got people living to 90. So they're still extrapolating for that. So they're just trying to create a general pattern based on the 1910 data, potentially. Yeah.
Good. So we're looking at very good. So we're looking at extrapolated data here. What factors do you think they'd consider here? What are the sort of 5, 10 different factors you'd consider here? And what do you think could also be the downside to this?
So they're probably considering obviously like improving management of certain conditions. So there's obviously like research going into like cancer research. So they may be predicting that we can better manage certain cancers or provide curative treatments for certain cancers. So that's one. In terms of kind of like again management, cardiovascular health, it probably they're predicting improved methods to prevent heart attacks and that sort of thing. So management of conditions is one. So improving management. Potentially improving public health campaigns between 1960 and 2010. Things like, for example, smoking. There's been non-smoking campaigns put in since 1960. So they're assuming that that's going to have resulted in fewer people regularly smoking or smoking at all who were born in 2010. Which is then going to result in those people not developing the certain conditions we associate with smoking, or it could be a similar situation, things such as alcohol and certain drugs. So then that results in people living longer because they're not getting those certain conditions.
And just on that, what has happened recently though that's been on the news? Yes, less people are smoking. Yes, smoking is a big, massive risk factor for lung cancer, cardiovascular disease, and everything else. It's one of the best things you can do for yourself. But what also, unfortunately, have we seen a rise in? It's not people smoking as much, but what could they be doing instead?
We have seen a rise in young people vaping, so using vapes instead.
Yeah. So that's important to consider, is like what the switch to it is and whether the data has actually considered that.
Yeah.
You've also mentioned in terms of treatment, but you're absolutely right. But that's very difficult to predict, right? Because what are you expecting? Are you expecting something to go linearly? Are you expecting it to go exponentially? Are you expecting it to actually have a point where it starts to drop off? So being able to predict that can become more difficult to do so, particularly when. What else would you want to consider as well? Because it's not only about the treatment, if it's there, what also do you need to consider?
It's also diagnosing it in the first place. So screening programs being in place now, so for people born in 2010 from a younger age, to spot certain conditions earlier, so they can put in a not preventative, but put in a, or intervene basically before the condition progresses too far beyond curative treatment.
Yeah, that's great. Fantastic. All right. Well, thank you. And I've just got one last task, and that's just on medical ethics, just to ask you before we finish up. So you're driving as part of your driving lessons that you just normally do. And unfortunately, as you're reversing into your driveway, you run over your neighbour's cat. What do you do and how would you go about this?
So obviously, I think the first thing to do is you've got to recognise, obviously, there's been a mistake on your part where you've not seen the cat and you've kept reversing, and unfortunately, like the situation's not turned out in a good way. So being honest in the situation is the first thing that's, the overriding thing you have to be. So you have to go and inform the neighbour and inform them personally. You want to do it yourself because obviously you're the one responsible for the situation. You need to go and inform the neighbour of what's happened. So I think the first thing to do, and it's best, I think, to do it in person rather than sort of calling, or if it's possible, and if they're able to come to the door, or if you're able to go and talk to them at the house. So I'd start just by kind of going over to the house and knocking the door and saying, hi, I'm sorry, I have something to talk to you about. Maybe do you mind if I come inside, just so you can sort of do it in a more private setting and you're not kind of doing it on the doorway and then kind of leaving quite quickly. So and then what I'd first do, just explain the situation to the neighbour, and obviously you can kind of expect them to be maybe quite angry or upset, and so when they're getting angry, just obviously not becoming frustrated yourself, just saying, you know, I completely understand why, you know, you're frustrated, and I'm, you know, really sorry that I played kind of a part in that. But then I think the best thing to do is offer kind of some sort of, obviously there's not a solution, you can't replace the cat, but offer some kind of way forward or plan forward. So maybe, you know, helping to move the cat, helping to bury the cat in the garden, for example, and also, you know, offering to, you know, come around to the neighbour, and obviously, because if it's an elderly neighbour, for example, the cat might be quite an important sort of social, quite important socially. So, you know, maybe you can, obviously, like I said, we can't replace the cat, but maybe you can come and come say, kind of spend time with your neighbour to sort of kind of maybe fill that gap in a way. You can also suggest things such as, you know, if she did want to get a new cat, you could help her in that process if they're sort of on their own and need help with that. And again, obviously, it's really, first thing is really important to do those when you go in is apologise and just kind of lay out the situation.
Just on that, like, how would you go about that? So you're actually initially having that conversation. Talk me through that in a bit more detail.
So I'd start by just saying, you know, I'm really sorry, but unfortunately, as I was doing a driving lesson, and as I was rushing out, I didn't look around thoroughly enough, and didn't see the cat running behind the car, and unfortunately I reversed over the cat, and then just say, I think unfortunately the cat's passed away, and I've gotten out the car to see and just to assess the situation. And I wanted to come to you straight away to talk to you about it and let you know what had happened, because I know obviously it's your cat and it's very important to you. And then I just sort of end up by saying, you know, again, I'm really sorry. It's, you know, I take responsibility for having, you know, reversed back without looking thoroughly enough. And then just give them some time, obviously, to kind of digest it and then understand what you're telling them. And again, if they become frustrated, then I think, you know, you have to be understanding of that, because it's quite a personal situation. Obviously, you're responsible for in a way.
Great, that's a really, really mature perspective to take. Thank you so much, Megan, and really appreciate your time in doing so, and we'll be in touch. All right, thank you.
Thank you very much.
So yeah, that was an absolutely fantastic interview that Megan did. She was really, really great there. And again, the main principle in all of this is making sure it's about how you think as opposed to what you know as well. And we've got much more of these MI and Oxbridge video recordings coming out. So be sure to subscribe and be sure to hit the like button as well if you'd like to see more of these videos. All right, guys, take care. Bye.